Hi everyone, this is Amrit and welcome to OsProEd. This video is for educational purposes only and please never practice medical skills without the proper credentials. Recognizing abnormal vital signs is very important, not only for the AMC exams, but also in everyday life when you practice as a doctor. Which one do you think is more worrying, hypotension or hypertension? Well, the rule to remember is hypotension is horrible and the worst thing ever. I will explain why. So basically, hypotension means decreased cerebral perfusion and unconsciousness can happen anytime. Keep in mind, it also means decreased perfusion to all other major organs. Well, let's see what can be some of the common causes of hypotension. Any condition that can cause a decreased effective circulating volume, so basically hypovolemia, impaired cardiac output due to the heart pump dysfunction, like a cardiogenic cause, or it could be an impaired cardiac output due to obstruction to the cardiac filling, so like an obstructive cause, and impaired peripheral vasoconstriction, so a distributive change in the flow. So some of the differentials that come to my mind are non-hemorrhagic causes, so volume losses, volume depletion, such as like diarrhea, vomiting, diuretic use, burns, sweating a lot, reduced intake orally, any drains or any pleural effusion. The common things are obviously hemorrhagic, bleeding, trauma, acute coronary syndrome, acute heart failure, pulmonary embolism, any drug-related cause, pregnancy, sepsis, anaphylaxis. So hypotension is worrying. You need to see the patient and you cannot deal with it over the phone. Oftentimes a MET is called. So think of the causes in the background and you should think of, would it be hypovolemia? Would it be a septic patient? Could it be cardiogenic, anaphylactic? Is it maybe neurogenic from like a spinal cord trauma? All right, so let's try and discuss a case. You are asked to review 67-year-old Mrs. Penelope who has a blood pressure of 80/40 and she looks unwell, she feels dizzy. What are you going to do? Tick tock, tick tock, tick tock. Well, number one, call a med call. Number two, what to do at the med call? Well, always DRABC, always. So DRABC and assess. DRABC and reassess. So does the patient look unwell? Take a quick history. You look for evidence of like all the causes that we just discussed and see, like was the patient admitted because of dehydration? Was it sepsis? Was it CCF? Was it like a fluid loss from surgery? On examination, look for things like, are they dehydrated? Are they febrile? Is there a source of infection? Are there crackles in the chest? Like, are they overloaded or is it, something to do with the fluid? So look at the fluid balance charts, the daily weights, see if there's any surgical drains in place and look at them, see, all these things, super useful. Okay. Now, speaking about management of hypotension, well, at the Met call, obviously try to determine the cause of the hypotension, then treat in the meantime. So if on examination they don't look fluid overloaded, you can start with a fluid bolus like normal saline, 200 to 500 mils bolus stat. Avoid dextrose fluid because this will be redistributed into other tissues rather than staying intravascularly. The principles of treatment of hypotension is number one, treat the hypotension itself. So fluid boluses, if not fluid overloaded, okay? Number two, try to treat the cause. So if it's sepsis, then administering antibiotics, treating the source of the infection, upgrade the antibiotics later again if needed. If the patient is fluid overloaded and hypotensive, then they may need ICU admission or inotropes. At the Met call, the team that comes to help can consider aramine, which is like metaraminol. In the meanwhile, there's need to determine losses. So you try and calculate like how much fluid have they had. So like, have they lost fluid because of a surgery? Was it like, something that happened during this admission? So try to look at the notes. Don't forget intraoperative fluid losses, and like stuff like this would be in the operation notes. If it's a cardiac cause, then inotropic support may be needed, not IV fluids. If it's anaphylaxis, then adrenaline and steroids will be needed. If it's medication management, sometimes you need to withhold some antihypertensives on the drug chart, things like that. So make sure that the BP and the OBS are rechecked more regularly, every 15 minutes or 30 minutes or 1 hour, depending on the situation. Make sure that you inform the seniors, and if there's no improvement, call a med call again. The patient may need to be in ICU despite everything that you do. That's okay. But that was hypotension in a nutshell for you. I hope that helped. All the best.